Welcome everyone to today's session. We'll be starting in just a few moments. A few reminders to everyone. The handouts were sent in your meeting invite. The CEs will be awarded 7 to 10 days. That means the certificates will be sent out to all that attend the entire session. And a reminder, if you have any questions, please put the questions in the Q&A box that's located on your screen. Again, we'll be starting here in just a few moments. We want to welcome everyone to today's session. Just a few logistics before we get started here. A reminder to everyone that handouts were sent and they were included in your meeting invite. So take a look at that. If you haven't found them, sometimes Zoom will go into your spam folder. So take a look for that as well. Also, a reminder to anyone who is wanting CE credits for today's session, certificates will be sent out to all participants who attended the entire session within 7 to 10 days at the conclusion of today's session. And also, if you have any questions, please feel free to put them in the Q&A box that's located in your toolbar as well. So welcome everyone to today's session on Innovating Person-Centered Care, a collaborative solutions for coordination and support. This session is an important session for all of us as leaders in healthcare. With all the dynamic changes in healthcare today, our session today will provide you keen insight on strategies for success within your organization. My name is Lisa Thompson, and I'm the Chief Operating Officer here at Pathway Health. And I've been in the post-acute care profession for over 25 years and have served in numerous clinical and operational roles, from vice president to administrator to CEO of a campus, and now COO at Pathway Health. Today, I am very pleased and honored to be joined by two additional esteemed colleagues. I would like you to meet my friend and esteemed colleague, Penny Cook. With over 30 years, Penny has been a student of culture through her work as a social worker, an advocate, educator, and leader. She most recently served as the Chief Culture Officer for the Center for Innovation after leading Pioneer Network, the umbrella organization for the culture change movement, to form an alliance with the Greenhouse Project. Penny was the president and CEO of Pioneer Network for 5 years preceding the merger. And through convening, writing, and advocating, she's working to create environments where we live the lives we want, no matter our age or our ability. And it's been an honor and privilege that I've worked with Penny in numerous roles and capacities throughout the past years as well. And our other esteemed colleague here and friend is Tiffany Robinson, and she's a dynamic individual that works for ComForCare, the franchise systems. She's worked for ComForCare for over 18 years as the training specialist, specifically onboarding new offices and helping facilitate their training programs. She works with the new and current franchise owners across the country, helping them build their teams, helping them really design and implement those very significant training programs. And she serves as a central resource for all of the leaders across the franchise. She has a BA in social work from Oakdale University in Rochester Hills, Michigan, and a certificate in instructional design from the University of Maryland. So welcome Penny and Tiffany to our panel here and to this fantastic session that we're having here today. Our objectives, as you see here on the screen, really will provide some key highlights for all the leaders here that have joined us here and care providers as well. We're going to look at some core elements of person-centered care approach to care that really impacts how we do our business, how we provide care, and impacting unnecessary readmissions, and really enhancing engagement and quality outcomes for individuals, no matter their care environment in which we serve and work with individuals. We're going to look at also some collaborative strategies for interdisciplinary team communication and discharge planning and safe care transitions. And we're also going to look at applying a practical system level team member training and educational strategies for really our high-risk older populations that really help prevent those avoidable hospitalizations and impact our overall care outcomes. For all of us as leaders here, we know our healthcare landscape continues to evolve, and we know that there are many things that factor how we provide care. And all of us as leaders have that goal to be able to provide the right care in the right setting at the right time and getting and achieving good quality outcomes. With the increase in complexity in care needs and transitions, a commitment to person-centered approach, which honors each individual's values, preferences, and goals, is really essential for us in improving outcomes and really supporting aging with dignity. So collaboration across all the different provider types and clinicians and determining and implementing coordinated care strategies, as well as looking at our community-based partnerships, really will help us with those care transitions and reduce unnecessary readmissions, and also making sure that we provide the right care in the right place and in alignment with the individual needs. So person-centered care is a high priority for all of us. Making sure that people are involved in and really central to the care is really recognized as a key components of developing a high quality healthcare system and a high quality healthcare organization. We know that the landscape is changing and the aging population continues to grow, and the need for what we all do as leaders is going to continue to grow. And the understanding of the healthcare needs, the complexities, as well as the consumer choice and expectations is something significant and also paramount for all of us as leaders as we look at how we design healthcare, how we provide education and training to our team members, how we upskill our talent that work with us, and ultimately, how we look at driving our service and our solutions. We also know that today's consumers and future consumers of post-acute care want and have more informed and are more informed and assertive about their healthcare choices. They're expecting a customized and respectful and really transparent care, meaning that they are engaged and involved throughout the entire process. They are really less tolerant of institutional routines and more likely to demand autonomy and a voice in their overall care decisions. Person-centered care is not just a best practice, it's a generational expectation. We know that person-centered care is not new. It has been around and has been a concept and really should be part of our day-to-day practices of how our culture of our organization and how we provide care and services to those individuals that we serve. It's an approach that really focuses on an individual goals, their values, and their preferences. It encourages shared decision-making between residents, families, and the care teams and the providers and clinicians. It promotes an integrated and coordinated care across settings and providers and prioritizes really dignity, respect, and autonomy in all aspects of care. In practice, it means that our clients or our patients are not just recipients of cares. They are active participants in shaping their plans and what they expect and their daily routines. So it has many benefits. Person-centered care and that approach has many benefits, and it creates that necessary relationship between a provider of care and the individual to improve care and outcomes for individuals. So what does it mean for us as healthcare providers? It means that all of us work collaboratively with our patients, our clients, and other healthcare professionals to do what is best for that individual. That we, again, look at the individuals, what they want, their expectations, and really respect the autonomy of the individual. So it's not a new framework. However, to this day, it's not embraced across all provider communities and across all clinicians. It is not a policy, it's not a procedure, it's a culture and a culture change that we need to make to meet the needs and expectations of today's future consumers. So why choose person-centered care as we look at everything? As you see here on the slide and the screen in front of all of you, it truly improves resident or the individual's engagement and really their emotional well-being and their autonomy through the whole care cycle. Again, getting the right care at the right time and preserving the autonomy and really respecting the wishes and the outcomes of that individual. Individuals who feel heard and involved are more likely to adhere to their plans and to what is needed in their care process. It supports better medication management, better really chronic disease management as well. And it truly fosters good, clear communication between the individual and all their care practitioners and other providers in the healthcare community. So again, receiving the right care at the right time in the right location or setting is important as long as it aligns with the individual expectations and preferences and goals. So Penny, you know what? You are an expert and have looked at so many different collaborative approaches, both nationally and internationally. And I would really want to defer to your expertise and ask if you would spend some time talking about a person-centered care approach, what it is, and how it impacts so many facets of care, including readmissions, and looking at engagement and enhancing engagement with individuals and their providers of care, and how it impacts quality outcomes, no matter the provider setting and the type of setting that we provide that care in.
Of course. And thank you so much, Lisa. And really, thank you for that great summary on person-centered care. I will never say I'm an expert on person-centered care because we as people ourselves are the experts, right? But I want to kind of switch things up a little bit and give us a little bit of a different perspective because I think we use this phrase person-centered care a lot now. And sometimes I feel that it may be becoming a little bit too diluted. We started as patient-centered care. We probably remember that. And then we evolved to person-centered care. And then maybe you've heard person-directed care. I want to introduce you to a concept called person-directed living. And then we're going to go back to person-centered care as well. Person-centered care, we're seeing more and more. We're even seeing it in some policy and regulation now. Person-directed living is a little bit of a different way to look at it. I think it's a term that we can all coalesce around no matter the setting we work in. That's really the first difference. And I also believe it's the closest term to succinctly describe how the majority of us, of all of us, want to live our lives. Because we do want to have some of those things that Lisa mentioned. We want to have autonomy. We want to be empowered. We want to feel like we have at least some semblance of choice. I think of myself sometimes a lot when I think about person-directed living, because 20 years ago, my life looked really different. I was waking up before my alarm went off at 5 a.m. I was trying to work out prior to waking up my young kids and getting them ready to school. For school, I had to drop them off, try to get to work for 8 o'clock meetings. You probably all, or some of you can relate to what I'm talking about because evenings were just as scripted. And sometimes I felt those days were so draining. I was drinking lots of caffeine. My two boys, their daily lives overlapped with my resources, and my choices for myself felt really pretty limited. And yet, I still managed to start my morning with a cup of very hot black coffee in my favorite blue ceramic mug. I chose what clothes to wear on a particular day because maybe I wanted a boost on that day. I wanted to feel a particular way. I decided whether I wanted to have a quiet commute with nothing that I was listening to nothing, or whether I wanted to blast my music. Maybe you get the point. Even with all those constraints I had, the system, the societal constructs, the family norms, and everything else, I was still able to have agency over aspects of my life. And that's really what got me through it. Next slide, please. And so before we go on, I just want to give that bit of a contrast between person-centered care and person-directed living. I was living in a very person-directed way, even when I had those constructs around me, because I was living a certain kind of lifestyle where I still got to lead the decision-making in my life. I still got to be the one that drove the decisions I was making on a day-to-day basis over my routines and my schedules and things like that. That was person-directed. Person-centered care is a great way for our system of care to have evolved to, because we really take into account then the individual's preferences and values and needs, and we respond to those. They're really at people themselves, the people that we're supporting and caring for are at the center of their care. I need to develop a graphic about this, but sometimes I think of it, the person-centered care has the person in the center, and then all the arrows are pointing to the person. Whereas person-directed living, a person's still at the center of that. So for instance, you or me, we're still at the center, but you know what? Those lines and arrows are going both ways, and they're kind of squiggly because person-directed living is more of a lifestyle. You know, I was thinking about this before we started, us as presenters, we were talking about our animals. And I was thinking about this particular thing regarding person-centered care and person-directed living yesterday, especially when I was thinking about environments and how much environments can impact this. And I was thinking about it in relationship to my dog. I have a 2-year-old Wheaten Terrier rescue, and she is afraid of everything, people and loud noises and everything like that. And so I live in the city of Denver, and at my house, she has a lot to contend with. Yesterday, I took her to a dog park. It's this huge dog park, all enclosed. I think the trail is 4 miles long, so she can run and play to her heart's content. If she gets close to somebody, she can run away. If she wants to go say hi to a dog, she can do it. If she wants to go in the water, she can. She has the agency, and she is the happiest that she ever is because of her environment. That's person-directed living that my dog has. When she's at home, I provide person-centered care. Everything kind of revolves around my dog Sammy for her life at home, but still she does not have that agency like I had in drinking my coffee out of my favorite blue mug every morning. Next slide. Because as Lisa said, what we're really looking at is to provide autonomy, empowerment, and choice to people. I like this graphic because I know that a lot of you are trying to provide autonomy, empowerment, and choice, not only to the people that you're caring for and supporting and serving, but probably to your team members as well. And that's hard because how do you highlight the needs of one person when you're caring for so many? Well, that's what we're going to talk about, because what I'm talking about for person-directed living is more of that lifestyle, providing the environment and the mechanism so that people can make their own choices. Next slide. Because what that leads to is greater well-being. So much research shows that individual agency, or you can change agency to self-determination, empowerment, choice, having the ability to make decisions as much as possible about our lives improves our well-being. Next slide. And what I can say now is that my life is different now in 2025 than it was 20 years ago. I don't have as many constraints on my time. Fewer people depend on me for their existence, and I'm really empowered to make choices that align with my values. That's person-directed living. The graph you see shows the relationship between person-directed living and life experiences. And I will say that normally, as we get older, we gather more life experiences. So if you go to the left-hand side of the chart, you'll see, and this is my life that I've kind of graphed out and projected further along. In elementary school, maybe I felt like I had a lot of control over the choices I was making in my day-to-day life. But you know what? That sort of went down for me in college. I felt that I didn't have as much agency. And you'll see when my kids were school age that I was talking about 20 years ago. Oh, I had a lot of constraints, as I said, and I felt that my choices were limited. Now, as I said, life is much different. And I feel that I probably have a lot of ability to direct my own life now. I know that may change. That may change as I grow older. Maybe I'll have a knee replacement, or maybe my partner will. Maybe we'll experience cognitive changes or choose to move to another living situation. Maybe I'll have more of those constructs and systems. And yes, maybe what feel like rules around me. And you know what I'll need? I'll need the ability to have agency over as many aspects of my life as I'm able. As I need more care and support, just as a lot of our clients, residents, patients do as well, my choices and ability to be empowered over my life may decline. And unfortunately, research shows that when I experience that decline in my agency, I may experience decline in my overall well-being too, which means for a lot of us working in this field, our quality outcomes. So what do we who work with people as they grow older have a lot of influence on? How to support people we work with to direct and make choices about their lives so that they can have greater well-being as well. Next slide. Many of our current ideas about person-directed living started in the community of people living with disabilities. You may have heard this, nothing about us without us, nothing about me without me. And once the number of nursing homes began to grow in the 70s and early 80s, this mantra became a focus there as well, because nursing homes were modeled after hospitals. It wasn't a design meant for people to call home. And in 1987, some of the small changes towards person-centered care that were happening in the world of nursing homes were actually put into regulation for the first time. And there was an entire section on residents' rights. Now that's carried over into other settings, and I think it's important to understand that relationship between provider-directed, person-directed, and then we'll take that a step further with the next slide. This is important because people are experiencing more care transitions as they go through their older years than ever before. So I think it's important for all of us to really have a deep understanding about the type of care transitions that people make and the type of organizations that they could be moving within as well. Those care transitions are increasing not just because of the greater number of older adults that we have. We also have a greater incidence of chronic conditions. And I would also say that we have more care options available as well. Think back in the 80s when I'm talking about nursing home regulations coming into effect in 87 with person-centered care. In 1987, we were just in the infancy of assisted living communities. We didn't really know what memory care was. Adult day, they were happening, but not as many. We didn't have those types of care transitions that we do now. And the world of nursing homes is where this graph actually started. And it was done by one of the organizations that I worked with, Pioneer Network, when we were participating in a research project in 2005. And we realized that there was a continuum of organizations that were either more provider or system directed, and those that were more person centered or more person directed. And I would say that system kind of is the umbrella over this graphic. So, in a provider directed organization, it's really the management and leadership that makes most of the decisions. And what that means is that not only do the people receiving care and support, older adults, those who are living with disabilities, not only do they have to accommodate the preferences of management, but staff members and team members have to accommodate management and leadership decisions as well. That's a very institutional way, I would say, of looking at things. Then we move to staff centered, where staff not only are consulted about what's going on in their organization, but they're really trying to be very empathetic and trying to put themselves in the shoes of the people that they're making decisions for. Once again, however, the people receiving care and support really are the ones who have to accommodate what's going on with the staff decisions as well. Then we move to what's more person-centered, and that's probably what we're all more familiar with, where we try to accommodate the resident preferences, client preferences, patient preferences as much as possible. And we really use people's goals and priorities, their own goals and priorities that they have for themselves, as the basis for their care plans and the support that we provide. And in this model, we see team members really beginning to organize their routines and their skill set and services around their clients. Now, in person directed, it's what I talked about. It's more of a lifestyle where people really are directing their lives as much as possible. And I just want to stop here and say that I say this a lot, people directing their lives as much as possible, because I realize that people who are living with cognitive decline, people that are living with significant physical decline, people with significant mental illness, and some people that just have never been asked, for instance, what they want in their lives may have a hard time doing this. And that's why I say as much as possible. If people aren't able to direct their lives, then we go to those closest to them. And in this particular model, again, staff really organize themselves around what people need. Now, this last box that you see is citizenship, and this is really interesting. Citizenship was added to this graphic by residents of a senior living community in Colorado. The organization that their community belongs to is Christian Living Communities based in Denver. And one of their communities, Claremont Park, the residents of this community developed the citizenship model and asked to have it added. And they did this in 2021 during the pandemic, because what they found is not only did the people who live in this CCRC life plan community want to direct their lives, but they believed that they were part of a larger community of citizens that included not only the residents who lived there, but the team members who worked there, the family and friends who visited, the vendors, the volunteers, anyone who came to this community was part of the community. And so they thought the citizenship really described that give and take, that idea that people who belong in a certain place have certain responsibilities as well. And I think this is really exciting. Next slide, please. Because I see so much of the work we do as being community centered. And that's why I love the idea of this citizenship model. Most of you on this call probably have a frequent role in someone's care transition. And I really see this interplay between person directed and community centered. Beginning in the 9th scope of work for quality improvement organizations, this was around 2008, CMS was pushing for a more community-centered way to focus on care transitions in order to reduce hospital readmissions. And so what communities found when they came together is that they needed to ensure, in order to figure out how care transitions worked in their community, they needed to look at a person and see how a person traveled through their community to receive care, going from, for instance, an acute care setting to a rehab setting, to an assisted living, maybe to a nursing home, maybe with some home care in between. How did the person navigate that? What they realized is they could put the needed platform in place to ensure organizations had the infrastructure, the communication, but organizations needed to pass along the information that was not only important for the setting, but also important for the person, their quality of life and daily life needs. So a community-centered approach supported person-directed living. I think CMS was really onto something, even though they didn't connect these two concepts at that time. I was doing some of this community-centered work on care transitions in Colorado. And what I found is that I needed to apply the same sorts of principles for person-directed care to this community-centered approach. I needed to go to the community agencies to get to know them, develop relationships with them, and see how I could support their work. This was really important to me because I started my career as a social worker in an acute care hospital. I was quickly assigned to a medical floor for people awaiting complicated discharge plans, either to a nursing home or maybe to home. And these were folks who maybe spent 6 months to a year and a half in the hospital with no acute condition except they had nowhere to go. So I got to know them really well. And as a social worker, had lots of notes for them. And when they were discharged, for instance, and they moved to a nursing home, one of my roles, one of my jobs was to send the packet. And the packet at that time, this was many years ago, was copied chart notes. And so I would stand at a copier and just copy charts. And I had the list of what I needed to copy. And then there was another section that said any other notes. If possible, and especially for those people that I was discharging that could not speak for themselves, I always copied my notes, even though they didn't need to be included, because I wanted the nursing home to know that one of my patients, Rosa, who was Spanish speaking only and who lived with dementia, could only be consoled if she had her baby doll. She didn't have family that was going to tell the nursing home that, and she couldn't tell them either. I wanted to make sure they knew that before she even got there. I wanted to let them know that the attorney who lived on my unit for 18 months wanted to get up every morning and get dressed and go to his office. We were able to convert a small broom closet in the hospital to make that happen so that we didn't have to chase him throughout the hospital every day. I wanted people to know that, so I specifically copied my notes. Next slide. Because I believe that no matter the setting, person-directed care, person-directed living applies to all of us. It's a lifestyle. We should all have the ability and be supported to direct our lives as much as possible, from primary care to long-term care. As I was researching this, I was looking at an article from Sweden back in 2024, and this is what the title of the research article was, quote unquote, being the main character, but not always involved in one's own care transition, a qualitative descriptive study. Being the main character, but not always involved in one's own care transition. I almost see that as being the difference between person-centered care and person-directed living. Person-centered care is you're the main character, but not always involved exactly in the care transition. Person-directed living means you're making it happen. Next slide. So I want to finish my section by just talking about some collaborative strategies for all of this. And instead of talking about specifics, how I like to view this is through a set of principles. Next slide. Because these principles not only enhance care transitions, but they also form the basis, I think, of person-centered care, person-directed care, whatever term you or your organization uses. These principles are for all of you in helping to enhance care transitions in your organizations. Know each person or organization. Knowing the person themselves, knowing your clients well, knowing your residents and patients well is so important. And getting to know the organizations you're working with well, as I said, like I was doing with the community work, getting to know those organizations so you know who the people are there, what they specialize in, how they can help you and your patients, clients, and residents. Because relationships really are the building blocks of transformation. One of the reasons that we're here today is because Homo sapiens, our surviving species that we're a part of, we exist because we collaborate and work together. That's the reason we are the only surviving species, is because of our ability to collaborate. Relationships are those building blocks. I also encourage you to move the decision-making for care transitions and every other aspect of them to those most impacted, which means a lot of times the person themselves. That idea of nothing about us without us, move decision-making to those where those decisions are going to have the most impact. And just like I did in copying those extra notes from the chart, even though it took extra time, put the person before the task. We have so many tasks, and we can almost make anything these days into a task and almost forget that there are people involved. Put the person before the task. And I believe that if you do these 4 things, you're going to come to this 5th bullet and you're going to be a wise leader. Leadership, I'm so happy that leadership is getting more prominence now in all areas of our society, because I think that it takes great leaders to make things happen. And I think leadership really comes down to a lot of common sense. And it takes a lot of emotional intelligence as well. Wise leadership is important because we're all leaders. Next slide. We all have a role to play in someone's care transition. We all have a role to play in person-directed living. So I encourage you, after you come off of this hour, really think a little bit about what's your role in care transitions, and even more importantly, what's your role in supporting person-directed living for your organization?
Penny, this is great information and such keen insight. I think about myself personally going through this, and with care transitions, with both my parents, and they have passed, but when they were going through their care transitions, and how the traditional model for my mom, who passed away prior to my dad, was a very siloed approach. I mean, we went from one specialist to the next specialist to the next specialist to the next specialist. There wasn't coordinated care, and it was all everyone telling my mom and my dad, who my dad was a high-level healthcare professional, telling him what to do. And here was me, myself, who understands this role, but when I'm a daughter, it's completely different. And watching those care transitions to then, fast forward a few years later, when my dad was going through it, it was more towards a person-centered approach, where, like you said, I love that, that art research article of being the main character but not always involved in one's care transition. That was my dad. He was the main character. We had a care team all around him. He was passed away from cancer, but again, he was not involved in his care transitions. People made the decisions. And now fast forward to today, with myself going through this. And to your point, I love the person-directed living. It really is. And I think about how I myself am an advocate for myself and embrace care and delivery of care and what I expect for myself, and being able to advocate for myself and have that autonomy, and working with my clinical partners because they're my partners, versus telling me what I have to do. And I fully embrace and personally have gone through this and seen those changes. I know, Penny, throughout all of this, you've seen those changes as well.
Very much, of course. Of course. I think that really applying it to all of us, Lisa, is what I'd like us to do first, because I think we can all think about experiences in our own lives where we've seen people struggle with the fact that they're not involved and
Hmm.
ourselves, and times when we've kind of taken the wheel ourselves and we've started driving and what that feels like and how that changes the outcomes as well.
Absolutely. And when we look at all of this and as leaders, we have to look at, to your point, we start individually, personally, and then how do we take those leadership approaches to apply that and to make those differences and changes in our settings and in the provider types that we are and the different roles that we play. All of us that are on this call here have different roles, whether it's advocacy, government roles, we are providers, clinicians, whatever we are, how we look at that individual that we're working with, not only ourselves individually, but then that individual, and how do we learn and teach, train, and upskill the talent. And the information that you provided, Penny, was truly gives us keen insight for all of us so that we look at strategies to improve. And however, knowing that we need a culture shift in how we provide that care today and beyond. So I want to bring our next panelist in with me, my friend Tiffany here. And Tiffany, I was wondering if you would share some insight on how you and your team have designed training programs and really strategies to enhance that collaboration and focus on how we provide care that's tailored to not only the home environments that you serve and individual needs, and really looking at that person directed living, because you see that day to day in the home environments and working with individuals, and how we do that to reduce those potential negative outcomes and really have safe care transitions.
Absolutely. So, what are our training needs? How do we implement our training, and how do we make sure our objectives in mind, such as person directed care? Our number one goal when it comes to training is enhancing our professional staff skills while improving the quality of care for our clients. We want to help our staff understand the importance of client choice in their everyday care. We want to enhance dignity and empower our clients while supporting their independence. We want to promote staff and client safety, comply with regulations, and then, of course, attract and retain quality staff members. So, when we're thinking about a comprehensive training plan, we want to think about how training provides employees with the skills they need to provide quality professional care. Employees who receive regular trainings are more likely to feel supported and engaged in their roles, and they're also more likely to be more satisfied and comfortable with their position. Training plays a vital role in the healthcare industry. It makes sure employees are well equipped to provide top quality care. It helps employees feel supported and engaged in their roles. This can actually help reduce staff burnout and turnover. Training can encourage career development and advancement opportunities. Adding training and education can encourage a higher interest in learning, and then that interest in learning can lead to a career advancement. For example, having a caregiver pursue a nursing career. Training can aid in stress relief and management. Employees who feel well prepared and supported in their roles do report having lower levels of stress. And training can lead to improved satisfaction of clients as they receive consistent quality of care. So, the more knowledge, skills, and experience your employees have, the higher likelihood for their productivity and effectiveness in the care they provide. So, the first part of thinking about a training plan is to think about not only providing initial training to new hires, but also ongoing training on at least an annual basis. It's always important to touch back on important topics to provide re education as needed. We want to make sure we provide the valuable training and support to our staff so that they feel comfortable and confident providing care, especially as we work in an environment where clients' needs and conditions can change quickly. As you create this training plan, You want to make sure you have clear goals. The first of those is to make sure we include all compliance requirements. So, of course, looking on a state, federal, maybe even CDC guidelines, any other guidelines you may be required to follow in your organization. On top of hitting all of the required content, you also want to consider content that you want to include that may not be required, but it will really add to the goal of your training program. Especially as we look at person-directed living, it may not be mandated that you include large components in your training program. However, doing so may have great effects on your client satisfaction. We want to communicate our training plan to your team and staff. Make sure that you encourage communication and that questions are brought to your training lead. Regularly look at your training plan and adjust, add, remove things as needed to ensure that you are constantly hitting the goal of the training you're looking to provide. Do not be afraid to ask for employee feedback, as this is how you can adjust and readjust your training curriculum to fully meet the needs of your staff. Ask, what items are we missing? Are there topics we spend too much time upon? Is the information presented in a digestible format? Feedback is key to building a program that is meaningful and successful. Let's now talk about ongoing surveillance. Many of us, using home care as an example, are already checking in for reassessments and periodic supervisory visits. Make sure you're taking advantage of seeing your professional staff members in action. Are they following protocols? If not, use this as a teachable moment. Provide on-the-spot training. Coach your team by example. Show them proper techniques if needed. Especially with our topic today, if we enter a home and we see a caregiver not including the client in the day-to-day decisions, we want to bring them back to the training you provide and on the importance of client autonomy and independence. Keep those lines of communication open and encourage them to reach out with concerns. Be available and respond promptly to staff training questions and concerns, always keeping those lines of communication open. So, how do we implement our training? What ways do we get the training to our team? The biggest part of a training program should be that the program is tailored to the needs of the staff and their clients. Different training methods you might utilize are instructor-led. So we're thinking about traditional in-person training, e-learning. Do not be afraid of venturing into the virtual world. E-learning can have huge benefits for your team. It allows training to be provided at the caregiver's fingertips. It can be available to them 24 hours a day. You can also add benefits such as gamification to your training, which adds small gaming elements to your training, which can encourage engagement and motivate caregivers with friendly competition. What about blended learning? So this takes in-person training and virtual training and puts them together. We're going to present some topics in person while allowing other topics to be covered in a virtual element. Coaching. This allows a more personalized approach to training with a one-on-one focus. Role playing. This allows your team to practice skills on one another in a low-stress environment. Job shadowing. This allows your team to see a more skilled and experienced staff member perform the skills and then learn from seeing those skills performed in person. These are only some of many methods you can use in your training. I recommend that you try different methods. Challenge yourself to find the best fit for your team. Now, let's talk about maintaining training success for the long term. Be ready to adjust and update training plans, not only to meet compliance requirements, but to meet your needs of your organization. We all want to be successful leaders to our team, and some tips for training leadership include being a lifelong learner, have a commitment to development and improvement, be open to learning. Sometimes, as a person who's been in a role or industry for many years, we feel we know it all. And we have to be open to what we don't know yet. Be adaptable. If one method isn't working, try something else. Be open to different learning styles and method. We have to be open to new ideas. We also have to be open to technology as it evolves and offers us new solutions for training. Respect your audience. I love training as much as the next trainer, but we cannot disrespect our audience by giving them too much information or training and not respecting their time. So, what is the right amount? What is the requirement of what we have to provide? And then, what is the amount that clearly provides the information in a digestible way? We also have to look at the needs of our audience and their challenges. If you have staff members struggling with the way that you are providing training, consider offering a separate training session to those that are struggling. Do they need a job shadowing session? Do they need some coaching through a particular skill? Be an effective communicator. Use clear language to build rapport with your team. We want to encourage continuous learning. Express excitement when your team finishes training. Consider offering a small token of appreciation when training is completed on time or if optional training is completed. And finally, do not be afraid to repeat training. Sometimes we need to see the content annually, and reminders on skills can be helpful. Let's move to the next slide. On this next slide, we are going to review an example of a training plan in action. In this example I want to share today, we're looking at a home care agency providing care to a client who has been in her home for 60 years. She has already worked with other agencies in the past, and she's not thrilled to be working with us. Her biggest complaint is that she doesn't like having strangers in her home telling her what to do. She does acknowledge that she needs help with personal care, such as bathing, dressing, getting in and out of her chair and bed, and is no longer able to keep up with keeping her home tidy or driving herself to run errands. The first thing we did, which we do with any new client, is perform an assessment and put together a care plan for our caregivers to follow. However, we really placed an emphasis with our nurses to make sure that care plans include the client fully in their creation. We want our clients, we want to know specifically what are their preferences? When does she like to wake up? What does she like to eat or drink? How does she like to spend her day? We want to start from the very first interaction with the client, showing her that we respect her. We want to provide support to her, but we will not take over. She is still in the driver's seat when it comes to her care. When it came to our training, our caregivers, we determined that we needed to include some newer aspects of person-directed care training. We want our caregivers to not simply see a list of to-dos and run through that list with a client. We want them to honor and respect the client with every task, making sure our staff understands the importance of not coming in and taking over, but instead making sure that the client's environment is safe, but respecting their autonomy. The training was provided virtually through our learning management system to our caregivers. We included courses on client autonomy, involving clients in everyday decisions, and providing support and safely, but not taking over. This helped our caregivers provide a more positive and fulfilling experience to our clients. We also provided training solutions for families by offering periodic workshops on important topics. A regular topic is person-directed living. It is not just the professional support staff who need reminders on this important topic, but also families who are invested in working side by side with us. This has been a huge benefit to family who may not fully understand the consequences of coming in and taking over as their family's physical abilities decline. Specifically with this client, we were met with a client who was not feeling constantly on guard with our caregivers. She felt very much in control of her caregiver experience. We found that allowing this client to go out and run errands like she used to be able to do on her own, but now with her caregiver, that she was still able to have this feeling of independence. The past agencies that she had used had their support staff run errands for this client and not allow her to be a part of the process. The simplicity of allowing this client to go grocery shopping and still be the person who is choosing the produce and the vegetables really allowed her to feel like an active member in the care. Her and her caregiver preparing meals together allowed the client to feel like she was not being pushed aside and not having any choices in her day, even something as simple as what would we be preparing for meals. Her two daughters, who lived locally, also attended our family workshop and both felt like they were leaving with a new perspective on helping their mother navigate her changing condition. Lisa, Penny, I'm going to pass the group back over to you.
Thank you so much, Tiffany, and thank you, Penny. I think about everything that we covered here today. And, there's a lot of information that we went through looking at the consumer demand and need, the provision of care from person-centered care to person-directed living and knowing how we approach healthcare and moving forward here. I just have a couple of final questions for both Tiffany and for Penny. And first of all, Penny, when you're looking at all of this and Penny, you've worked across the nation and you've seen a lot of collaborative and innovative models. Can you tell us some thoughts that you have of how a leader can begin this journey and working with their organization? What are the steps they need to take in order to move themselves from a siloed approach to care to really centering in on the individual and moving forward here?
Yeah, it's a great question, Lisa. And I really think it depends where an organization is sort of on this journey. So I would say that that's the first step. I think that leaders really need to look at their organization very authentically and transparently and bring in as many voices as possible. Bring in voices of team members, of all different sorts of team members. Bring in voices of whomever your clients are, whether you refer to them as patients, clients, or residents. Really get a handle on what people think of the environment that they're working in and what they're living in. I would say that's the first step. It's almost like shedding that layer of thinking as a leader that you have all the answers and almost
Mhm.
saying, I have no answers. I just want to keep asking questions and be curious on what's going on in my organization. I really think that's the first step.
Thank you. And you're right. I mean, leaders, part of that, all of us here that are leaders is looking at, we can sit back and think about what Penny and Tiffany presented today and think about saying, does that reflect who we are as an organization? And to yourself, it's the authentic self and where you're at currently to assess where it is to begin those next steps in this journey. As really, it's the best way of providing that care and services. And all of us, as Penny brought through this process, is saying, look at ourselves individually and how we want to have that journey for ourselves of having person-directed living. And it leads me then into Tiffany when we're looking at training and education. And really, can you just tell me a couple of things for leaders, how they can go about and assess what their current programs look like today and how they can align with, as they're going through this journey, how they can align with and making those changes? What are some key things they need to do right now?
I think the biggest part of this is realizing that this is a culture that we need to cultivate. And so a lot of times, I understand this. Our caregivers have a huge to-do list. I have to see this many clients. These are all the things that need to happen. And they may be walking into someone's room and deciding for themselves, this is the quickest way to get through this list because I have other things to do. But we really have to flip the script on that. We have to make sure that our caregivers understand the importance of coming in and not taking over and not thinking about all of the other tasks that I have to do when I leave this room. So we need to provide them with some training that really shows them the benefits of allowing clients to have decisions. And some of these decisions are quick. It's not something that's going to add a huge amount of time to your day.
Mhm.
Instead of telling a client you're having a sandwich for lunch, it's what would you like for lunch today? It looks like we have things for sandwiches. It looks like we have things for soup. What would you like? Simple ways where you can just allow that client to be involved in the process is huge. For us, what we've done is we like utilizing a online training, and we have utilized some third-party trainings that we have rented, and we've also created some of our own. And that's something you're able to do in a lot of these learning management systems, is give your employees training that is really accessible to them. They can access it wherever they are from their smartphone. And I think caregivers also really appreciate that, because they do have a lot going on, a lot of things to complete. So if we can make it easy, that's going to be huge. But the big part is changing the culture.
You're right, Tiffany. And all of this is, this session today really brought keen insight for all of us. And I can't thank you enough when I look at this, Penny, and I look at everything that we're doing here today. The changes that we have going on in our profession and what we're doing today is key and critical as we all move forward here today. And I can't thank you both enough for everything that you provided here and the keen insights. We had some great questions that we were able to answer throughout. And a reminder, we would love everyone to join us in our next session that is coming up here soon. You'll get more information on that. And those of you that are requesting nursing credits, as well as administrator credits, social services credits, and the other credits that we have available to you, if you've attended the entire session, the certificate will come out to you in an email within 7 to 10 days. So thank you, Penny. Thank you, Tiffany. You guys are phenomenal and really gave us, all of us, a lot to think about. Thank you for joining us here today, and we look forward to seeing everyone soon.